Firstly, I just want to thank all of the speakers, and there's been a lot of chat, and we're very grateful for your generosity, Professor Cherry, Deborah Gold, Lisa Brossu, and Simon Smith. I don't know if you're prepared to stay on a bit longer. If not, we understand, but if you want to stay on a bit longer, maybe we can have some more discussion. Otherwise, like I said, we're really grateful for your presenting and being generous with your time. And I especially want to thank the OCO team that supported this, and also Alec Farquhar, who's been the catalyst behind these sessions as well. So we might just keep the channel open anyway for those who want to carry on talking. But just, the session is actually officially finished, but we're going to keep on talking if people want to stay on. And I don't know if Deej or John are still on, if they wanted to comment on that last question, or maybe we can move on to another question. I think it was pretty well answered, unless either of you want to make a comment on that, the United Kingdom position perhaps, or the Californian position.
I can comment on the effectiveness of respirators. I mean, we reviewed a lot of studies in writing the standard, and we've relied also on, in experience of NIOSH and everybody else. A lot of, even studies that were heaven cited by the people who don't support respirator use compared to surgical masks have found differences in influenza-like illness, even though they claim to not find a difference between the two things. So I think that I think in some ways this has become a political issue and is less of a science issue, because we know as industrial hygienists, we know what it takes to prevent the entry of particles into the respiratory tract. And we would never say, go out and grind that silica or, work with that lead with a surgical mask on, because we're going to inhale lead particles or silica or whatever it is. And I think that should be sufficient, but I do think there are clinical studies that do demonstrate the difference.
Yeah, I know there was I'm sorry, John, over to you.
Yeah, I was just going to say, I think, I agree entirely with everything that's been said. And I usually try and put it in this sort of way that, if you're going to send your mother or daughter or whatever into a ward where they were doing aerosol generating procedures, which would you choose, the surgical mask or the respirator? And I think, without exception, people choose the respirator because it's this, you really have this conservatism built in. You want to ensure you get the best protection you can in amongst all this uncertainty.
What we're seeing, though, is a lot of the procedures around AGMPs, and it's the non-AGMP exposure that could also produce, be a risk from somebody coughing, for example. So, if we lock into those AGMPs, and I know I've spoken to Lisa about this as well, that's a concern.
Well, it is true that hospitals do have higher rates of ventilation, and that may be helpful. It may be helpful in those contexts, but most other workplaces do not. Again, I want to point out that there's actually been very good work with tuberculosis, and in fact, there are CDC guidelines for tuberculosis in homeless settings and in settings of incarceration. And they don't talk about the use of surgical masks. It's not even a discussion item, and it's not a discussion item in healthcare. So, everyone says, okay, well, tuberculosis is not like, it's a bacteria, but there are so many things about tuberculosis that are like this particular outbreak. If you look through the literature, you will see clusters. You will see descriptions of outbreaks where one person who's infectious with tuberculosis goes into a bar, and everyone in that bar or many people are infected. The analogies are very appropriate. It's an aerosol. It's generated by speaking, by talking, by breathing, by coughing, by sneezing. It's a very hardy aerosol. It stays alive in the air for long periods of time. it is both aerosol transmissible and airborne in the context of the definition of airborne. And I think we need to start thinking about it and going back to what we know about measles and tuberculosis and start thinking about it in that context, because we've done a lot of solutions for especially for TB that are very relevant today. There's discussion of UVGI, UV germicidal irradiation. There's lots of research around that, and it works well in some contexts.
Just mention something on aerosol generating procedures. Thanks very much. In again the Canadian standard, we have gone into a selection guidance for biological aerosols. We recognise that the ambient airflow, air changes, actually are to be considered in selecting the type of respirator. And so, although I might use an N95 type filtering face piece in areas with high ventilation with an aerosol generating procedure for SARS-CoV, if the ventilation is poorer, say it's being done in a patient room or leads in the corridor, if things get that bad, a higher level of protection will be recommended. That will mean going to powered air purifying respirator. And so some of us in the community aren't even comfortable with an N95 type product. There's a blanket provision for aerosol generating procedures.
The other thing I'd like to say about respirators is that, we're all, and I, congratulate Simon on highlighting the fact that, N95 filtering face piece respirators are the bottom of the respirator hierarchy. If we had, and there was a good IOM, National Academy of Sciences study and report about different kinds of respirators during pandemics, and they discussed the fact that elastomeric respirators might have a very, key role. And if we had or were to purchase an elastomeric respirator for every single frontline healthcare worker or healthcare worker in general, we would alleviate all of the supply issues. And not only that, we would have respirators, like N95 filtering face piece respirators for everyone else, because we have so many other workers who do need. I mean, we cannot solve the problem for every single worker with ventilation. There are those who in essential work, workplaces and doing essential work that need respirators, but they're being told you can't. And so what they're being told is to wear face coverings, because we can't even give them surgical masks, which I wouldn't, there's not much difference between those, but face coverings is even more ridiculous. They don't even come close to being a personal protective equipment. But now you see, not only does CDC recommend them, they're now starting to say that workers should wear them, and workers should wear them if they can't physical distance. These are egregious recommendations. We should be holding their feet to the fire and saying this is unacceptable. This is not how we protect workers.
Thank you, Lisa. And just on that, so last Friday with the point of care risk assessment webinar that we provided, people that are doing a point of care risk assessment should be asking questions about ventilation. So that should be part of the point of care risk assessment. What's the work environment like? And there was so just taking the discussion away from respirators, I can't find it now, but I think I can remember it. Val Wolf asked a question, with the calculations that you provided, Lisa, and Val was talking about occupancy. Can the calculations that you provided help us make decisions about occupancy? Sure. I think I've captured that.
Yep.
In congregate living.
Oh, sorry.
Sure. You can easily, if you can figure out how much one person generates, you can add more people to the mix.
Okay, thank you. Let me think. Another question. So the hyperlink's been put into the chat box around the ATD standard. Thank you very much for that, Dorothy. and there's a lot of discussion around, I'm just trying to find something that's a little bit more, regarding probability calculations for infective dose, over what time period of accumulating variants should we be concerned? It would seem that total number of variants exposed to over months, years, lifetimes would not be important compared to the accumulation in a given hour or at a single moment for a particular exposed person, such as the hotel room cleaner. Put another way, at what time interval does the body forget it was exposed to a given variant? Oh,
So that's a good question. Can you hear me, Kevin?
yes.
Yeah. It's a good question, and it's one I don't have an answer to. So and I think someone else asked the same question earlier, that is it an acute exposure? Is it a chronic exposure? I don't know. We do have defenses. We have defenses to fight against infections. So it probably is not a chronic exposure. But it's probably not a long-term 40 hours a week, 40, 20 years of working or whatever it is. But I've been making my calculations on the basis of a day, a working day, for example. Seems a reasonable approach. If you're worried about trying to control someone's exposure, let's focus on a day.Maybe it's a week, but maybe I don't know. We don't know the answers to that. Nobody's done the animal experiments that would elucidate what is the nature of the exposure that leads to infection.
Thank you. And I just want to make a comment there. We've talked about ozone generation. We've also talked about, ultraviolet UVC as a sort of a disinfecting agent. And the issue here could be that we could be exposing workers to other hazards. So rather than go and introduce this kind of technology, they really need to do a risk assessment around the exposure to those things as well. And I know you did say that UVC is very effective, I guess within, say, ductwork, for example.
Well, the problem with UVC is, my understanding is that it's pretty good with TB, but it's you need a longer contact time for it to kill a virus. And so that's the piece we don't really know yet, is what is the length of contact time needed with UV. So it may be that you have to adjust what we know on the basis of a different organism.
And
okay,
used,
and I just
can I say something about UVC? Because they used it during the AIDS pandemic before we had drugs, and they used it at San Francisco General upper room UVC for people who were getting aerosolized pentamidine, because they may also be infected with TB. And there was some suggestion it would be that upper room UVGI might be useful, but it is incredibly important in designing, what Lisa said, it's incredibly important in designing UV that you have the air circulation characteristics that are going to support disinfection. And in most circumstances, we don't. And in most circumstances, we don't have the expertise to actually design them. So, that's just a concern. It's not like plugging in an air filter. And even with plugging in an air filter, you have to be sure that you're actually getting the air circulation by the air filter that allows it to provide effective room cleaning. So a lot of times we do see hospitals bringing in a portable HEPA filter, but we don't know that you're actually increasing the air changes, the effective air changes per hour by doing it.
Yeah, so you need to measure.
Right, you need to measure, you need to design. And like in school situations, one of the things we're very concerned about now, there are like a real lack of knowledgeable maintenance people and engineering people in any school system, at least in California. Maybe it's better in Canada.
Thank you. I've got a question. I've got a comment here from Nancy to everyone. AII rooms, so they're infection isolation rooms in a large Toronto hospital during Ebola, were found to have been operating at positive pressure for years. OHS expertise is wanting in the healthcare sector. So, I guess in these units, these critical units where the COVID patients, the hospitals really need to look to make sure that they've got the proper kind of isolation in place with the negative pressure. And I think they talk about 12 air changes per hour. I don't know if anybody else wanted to comment on that.
The health department did a similar study in Oakland, California, of a public hospital there back in the 90s and found pretty much the same thing. And we find that a lot when we go to airborne infection isolation rooms, is that they often are not either providing the amount of airflow, or they're not under negative pressure, or they're not being used. They're using the wrong doors for entry and stuff like that. There's a lot of problems with them, with making sure they function correctly.
Great. And I guess, with the World Health Organization about to review their position, and I hope they do, thoroughly. There's going to be so much more focus on ventilation and higher order controls. So, we know that there is a high likelihood that it's airborne. So really, we should be now focusing on making sure that all those controls are in place. Now, I did. I lost my train of thought. Sorry. I was going to say something. Oh, yeah, there was a question to John, to Professor Cherry, about how long the efficacy tests would take. I think you talked about efficacy of different controls, the localized exhaust ventilation controls. John, are you still with us, or have you left? You might have left.
Yeah.
I'm just wondering, does anybody on the line got a pressing question they'd actually want to ask themselves? As I said, we've got a lot of questions here, and we can actually go through the questions and, really try and, be reflective in providing some of the answers back. But it's always useful to have someone on the call ask a question in front of everyone else. So I'm just wondering if anybody would like to do that. Are we able to do that, Tony?
People can unmute themselves.
If you want to unmute, anybody wants to unmute themselves and ask a question?
Just one at a time, though. I guess I have a question about congregate living and maybe Deborah, from the Cal OSHA perspective. We're doing a lot of work with migrant farm worker, trying to promote COVID prevention. And it's very challenging with the living conditions here. And I know that it occurs elsewhere in the US, and you referred to the prisons. And I just wondered about any solutions or any sort of advice, potentially using some of the calculations that Lisa showed around limit, 4 to a washroom limit. I know that there's spatial and other design, or minimum air changes, things like that. Anything that's available that we could apply to that population and that risk?
There was a presentation by the Migrant Health Support Network, I think it's called, or Migrant Health Network, maybe, that looked specifically at conditions in ag and for farm workers, including this whole issue of what would be peri-occupational exposures, both living conditions and transport. Because people are loaded in the back of vans, closed up vans, and transported to work sites, whether that's legal or not, which in California, it might not be legal, and in the United States, it might not be legal because there are regulations about transport of workers. But nonetheless, that is what happens. And, so it's really hard. But like I said, there are people trying to address it. I don't, so I mean, it is a problem, and it's likely to be part of the problem in all of these other outbreaks. Congregate living is a little easier for us, whether it's licensed, because there are some recommendations from California Department of Public Health on congregate living facilities that, you know, address issues like separation between infected and non-infected, separating the staff who's going between infected and non-infected. That's been an issue with the federal prisons, with the state prisons. That's what I got to say.
There's a comment here in the chat box from David Abrams to everyone, and it's something that I've noticed too. When you're out there in the public, you know, and you see people wearing you know, face coverings with ear loops, and there's also been respirators that have been marketed with ear loops. But ear loop, and so David Abrams says to everyone, ear loop masks are not respirators per se. A respirator needs to have straps high and low to achieve a good fit. I think it's critical, like, you know, you're trying to look at what works and what doesn't work. And I know that, I think it might have been certain types of respirator that came from China had ear loops. And I did speak to Simon about this, and he provided a lot of good information back about that. So, you know, just some information. I think also Kimberly asked a question about the evaluation of you know, the impact of decontamination on respirator fit. So we're just going back to respirators again. So, you know, if we do decontaminate them, is there a, you know, do we change the way that they'll fit? And I know Workplace Health Without Borders, they were talking about leaving a respirator for 7 days and then almost like rotating through sort of 7 respirators and then going back to the first one. But I don't know. If anybody wants to talk about that, if you've muted, Deborah, I think.
So, Kevin, I did work on, I did write an article about decontamination and did review several of the decontamination methods that looked most promising. But my big problem with decontamination is that we have some data that suggest that filtering face-piece respirators, and I think Simon mentioned this as well, you know, after some period of time begin to lose their ability to fit, and it's because they're not designed to be donned and doffed multiple times. The straps will give way. It'll be harder to just the very form of the respirator loses conformity, and you know, the nose clip starts to fail, and all of those things are really important in fitting a filtering face-piece respirator. So the data suggests that after 5 to 10 times a donning and doffing, that's when you start to lose the ability to fit a filtering face-piece respirator. Well, that really doesn't make decontamination very cost effective. There's a huge amount of logistics and other things that go into managing the decontamination of a respirator. But the other piece of the puzzle, I think, is that none of these methods have been really well evaluated with respect to either filter efficiency or fit or long-term comfort. There's a small amount of data and just a few studies. Some are peer-reviewed and published, some are not. And yet, and I have to tell you, it was never anything I ever saw. We never discussed in the context of pandemic influenza planning. So I was pretty shocked that people were talking about decontamination of respirators. It's not what we should be doing. It actually, I don't know what Deborah would say about this, but in the context of NIOSH certification, anything you do to a respirator negates the certification. I know CDC and NIOSH have said, well, in the very extremist circumstances, you can do this, but they do not recommend it. It is really truly a last resort. And you did mention the reuse reuse over time with leaving a respirator. That's actually a suggestion that CDC made, that you give a healthcare worker 5 respirators. They rotate between those 5 respirators and simply don't, by the time you get back to the first one, whatever's on that respirator has lost viability. That's a much better solution, I think, if you really need to reuse respirators than decontamination.
Thanks, that's
yeah,
great.
I agree with Lisa. And also there was a UCSF study done recently looking at reuse and extended use as an and the ability to provide the fit factor required, right? And they came up with some recommendations on limitations of both extended use and reuse, and that's without adding the stress of decontamination. I don't know. I think that's a pre-publication study, but it was pretty. It was pretty limiting as to how far you could go with these strategies and still provide the protection that people need.
Thanks, Deej. Just there's a comment here from Maria Possumai to everyone, and this is a really important comment. Hold on, no, it's not. Is it? Yes, it is. The surgical mask versus N95 respirator studies, especially the ones by Loeb and Cito, are being used by PHAC and WHO as bedrocks to their arguments. Should there be papers and studies that address the studies on summarising the arguments set out today by our excellent experts? I'm not familiar with Loeb and Cito, but obviously there's papers there that PHAC and WHO are using as bedrocks for their arguments. And I think it's very important that, we try and get our hands on these studies just to show that, surgical mask isn't personal protective equipment, and to demonstrate that there is a difference. So we've got, I think we might fold up at 2:30. I don't know if there's any closing comments from any of the speakers that are still online, from yourself, Deej, or Lisa, or Simon. Just closing comments from yourself that, gems, words of wisdom that you want to leave the group. This is being recorded, and like I said, the questions are going to be pulled together, and we're going to try and provide a kind of more of a kind of concerted response to all of them. So I don't know if you want to share some closing comments. And I just, like I said, thank you so much for fabulous involvement from each of you. Thank you. But if you want to, any closing words? Not from you, Deej, Lisa?
I guess my closing comments are that we, as occupational health and safety professionals, really need to work together. We need to convince people that aerosol transmission is a real thing. It's important. It's an important mode of transmission, and it requires more than, face coverings and even respirators. It does require exactly what we've been talking about here, more attention to the other parts of the hierarchy of control, source controls and pathway controls. But the answers are not simple. A lot of these questions people are posting, tell me what I should do in this situation. What should we do in this situation? Unfortunately, with aerosols, it's a little bit more complicated, but I do think we have the solutions. I do think there are solutions out there. It will take all of us to work together using the instruments and methods and modeling that we have available to us, that we've used in many other settings, including complicated ones like pharmaceutical aerosols and nanoparticles and other similar problems. And even if it's just control banding, there are ways to solve this problem that don't require that we tell everyone to wear a face covering, because that's not the solution. Thank you.
Thank you. Simon.
Thanks. I think I was muted there. I couldn't speak. I had a couple of comments about the Loeb study you mentioned. That was examined in the Canadian standards development, and we found that it was not powerful enough statistically for the conclusions that we drew. And it's a shame it's being used by authorities now in making protocols. But thanks so much.
Sorry, just on that, Simon,
yeah.
Would you mind responding back to the question on the chat box then? Like maybe you can provide a response on that, what you just said later on,
okay.
After this, great, that'd be fabulous. Thanks.
I'll try, yes, I'll try to. Thanks, yeah. And just, I guess, to conclude, thank you very much again for the opportunity to present. And it's, I guess, very, very fast moving, very, very interesting area. If anybody has any questions, I'll have my email on the presentation, and be happy to share this and other information I've included in the extended slides in the presentation. But thanks very much again.
And just for everyone's benefit, Simon also presented through Workplace Health Without Borders, and that's also on YouTube. And Simon also presented to St. Michael's Hospital too. So that's also been shared as well. And we're very grateful to have Simon also share his knowledge with us as well. And just going back to Dr. Brossu also, we're very grateful. And also Deej, I mean, it's really hopefully we're breaking some new ground here. We're trying to make some changes in providing this webinar. And without any more comments, I think we'll close the webinar. I just want to thank everyone for great participation and questions, and to our presenters. Thank you.